I think it's important, and I will focus my talk on EEG, just in addition to Roberta Cilio's talk, because we are just neonatologists and we are not neurophysiologists and we are not child neurologists, but you want to monitor babies. And there was a survey in 2010 addressing this problem. Do you have access to EEG, full EEG? Do you have access to continuous EEG? Do you have access to amplitude integrated EEG in your unit? And I like to ask the audience, just by lifting their hands, do you have access to continuous full EEG? I think there are 5. Do you have access to AEG? So that's a lot. And do you have access to, let's say, out of office hours to full EEG for, let's say, 30 minutes, 45 minutes, out of office hours? Just a few. So basically, the vast majority don't have access to EEG out of office hours. And, but still, AEG has its learning curve also. It's like everything you monitor, you have to learn how to look at this. And this will be the focus of my talk. And we use AEG in different conditions. And as you can see here, and it's different. AEG is immediately available in our unit. The nurses put it on the minute the baby is in the unit. You can monitor for a long time. It's no detail, but it's based on pattern recognition, and opposed to EEG, which is difficult to interpret. And I think you really have to realize what the skills are of your neurophysiologist as well, because if it's a neurophysiologist who is only dealing with adults, it's very difficult for him to read a neonatal EEG. So for those who are not familiar with the technique, the EEG is filtered and there's an amplification. It's very compressed and it is on a semi-log scale, and you can have either 1 or 2 channels. And this is how it's compressed. So this is a lot of compression actually. So it's no wonder you miss a lot of details, and you have to bear this in mind. These are the background patterns we look at in term babies, and I will come to preterm babies later in this talk, and I will present hopefully some other special cases, special conditions, if we have time enough. So in my talk I will focus more on the examples. In your handout you have more slides on the background. So right here you have sleep-wake cycling pattern. And here, when the bandwidth is broadened, you have deep sleep. Note the time base between those 2 lines is 10 minutes, and not 1 second or 3 seconds as you have in EEG. And note the time, the excess with the semi-log. You have this semi-log scale. So this attenuates the lower amplitudes. And here you see this discontinuous pattern with activity below, or as less active, below 5 microvolts. And you have absolutely abnormal images of patterns. Here, burst suppression, continuous low voltage around this 5 microvolts, and flat trace. So I want to go into AEG without cooling. And as you all might know, that there was a meta-analysis of the prognostic value of AEG in asphyxiated babies. And the sensitivity was very good in those early hours after birth for a bad AEG pattern. And the sensitivity was also quite good. So I like to demonstrate here the pattern of a baby who was born in our hospital, and she had bad Apgar's cord due to cord around her neck, And she was in the unit within an hour after birth. And as you can appreciate here, you have the birth suppression pattern. Here a lot of movement was going on, leads were falling off. And here the baby is recovering in terms of her EEG and clinically as well. And here you see within 6 hours after birth, she recovered to normal amplitude in this EEG. And she was normal at follow-up, and she didn't have ultrasound or other imaging abnormalities. This is another baby. This baby was referred to as from another hospital. I had to pick up this baby, and it's always in the middle of the night, as neonatology know this. And then this was a very sick baby. And he was on the ventilator. He had severe hypotension. We treated him with a lot of inotrope medication, with filling, so it was a very sick baby. And within those first hours after birth, we have here this birth suppression pattern. And due to his clinical condition, his blood pressure dropped further below 20 millimeters of mercury. And we did a lot of, we gave filling, and then his background pattern recovered. And within 24 hours, he had almost a full recovery. And here I want to stress that it is very important for the nurses to write down what they're doing, because you see these events, and these could be seizures, if you just look at the EEG. And because I was very worried about this child, and he was still in a very bad condition in terms of respiratory and circulatory, I asked for full EEG, because I didn't believe actually what I saw, because the child was very ill. And they reassured me, said, no, the EEG is normal, there are no seizures, and it's an almost normal background pattern. And just an hour later, we had that picture, and here you see, and this baby, you couldn't see, in this baby, you couldn't see clinically, you couldn't see nothing. You couldn't see anything, because he was operated upon, so he had a lot of medication, and he wasn't moving at all. And here you see that there are these patterns here in the borderline of the trace, and you have these big hums, and actually it turned out it was all seizures. So we think that this is a sign of secondary energy failure after a severe hypoxic ischemic event. And actually the background pattern deteriorated severely in this baby, and eventually this baby died. So it's all about timing of the insult. Do we know that is this event around birth? Is it an acute event around birth, like an abruption or something like that? Or is it already there before birth? In a lot of circumstances, you just don't know. You reanimate a baby, you have a baby in a bad condition, and you just don't know. So that is very important. As we can see in this baby, this was a term baby, and here you see a 2-channel recording. And you see here the EEG on the left-hand side, here on the right-hand side, and here you see the right-hand side raw EEG on this particular channel, and you see here the left-hand side on the raw EEG as well. And this baby had normal APGAR scores. This was fitting within 3 hours after life. And then after birth, sorry. And we had this very depressed background pattern, which was even more so on the right-hand side, and so more or less birth suppression pattern. And you see these little hums, which turned out to be seizures. So there were a lot of seizures. And this was the MRI with this particular baby with a severe watershed injury, probably from antenatal onset, because when we do the EEG in our unit, or when the baby comes in a few hours after birth, we already have access to ultrasound, so we can do an ultrasound immediately when the baby is in. And then already on ultrasound, we saw these abnormalities. And you will appreciate that on this right-hand side, these watershed injuries were more pronounced than on the left-hand side. So this is all in the uncooled situation, and one of our colleagues evaluated this. So what happens to those babies who start off with a bad, really depressed background pattern, that is to say birth suppression, flat trace, continuous low voltage within 6 hours after birth, and due to the, and we already know that a lot of these babies will die or have a moderate to severe handicap, and they're not cooled, but quite a few recover. And what happens to the baby who recover within these 24 hours? You see that 20% of those babies do recover, but of those 20%, around 60% of those babies do quite normal at follow-up. And so we have to continue monitoring these babies to see how the background pattern evolves over time. And another way of looking is looking at sleep-wake cycling patterns after HIE or during HIE. When sleep-wake cycling pattern already exists before 36 hours after birth, we know that this baby will recover and that he will be quite normal at follow-up. So that's important. So this is all in the non-cooled situation. And then a lot of neurophysiologists, maybe in your department as well, will say, yes, but this baby was depressed because he was on phenobarb. And I can't access this EEG because he's on phenobarb or he has some other medication. And right in this group of babies, we saw that even with anti-epileptic medication, you can have prognosis within those early hours after birth, and only when you need a lot of medication, then it will really depress your background pattern, and your prognosis is influenced by this. Again, timing of the insult. Oh, sorry. So another way of looking at outcome in terms of full early prognosis and outcome is what already was mentioned here, is near-infrared spectroscopy. Then you look at the cerebral saturation, and you see in babies that are very encephalopathic that the saturation of the brain, so the mixed venous saturation, is going up after 24 hours. So in the babies who do bad, the saturation is going up after 24 hours. So that gives you an idea about prognosis as well. And here you see the MRS in association with this. Another way of looking is at the EEG is at absolute values. So we tend to look at pattern recognition, and I think that's the preferable way. And I'll show you in a minute why I think that. So here you see that above 10 and 5 microvolts, you have these normal traces, and here, so it's divided in 3 ways: normal, moderately abnormal, and severely abnormal. And this is always difficult in terms of prognosis. But what about this baby? This was a really asphyxiated baby, very, very asphyxiated baby. And who would assess this EEG? Who dares? Actually, it's a bit odd. I mean, the bandwidth is too narrow. The baby is encephalopathic clinically. So why this EEG? And that's because we have this one channel, we have this ECG artifact on the EEG. So it's almost a flat trace, and the only thing we have on the EEG is the ECG. And right here, we have a seizure. And here you see that. So it's important to recognize this artifact. Otherwise you would interpret this EEG as normal, this AEG as normal, which isn't, obviously. It's a flat EEG, so a very severe condition. And I'll show you here that why we have this problem. And you see here that we have a full EEG, and from this full EEG on different sides, so this is the frontal area, central area, temporal area, and occipital area, there are different patterns. But you see that the baseline is lifted, especially here in this temporal area, due to this ECG artifact. So especially in this area, where you have conduction via your main arteries of your ECG, you'll have this problem. And on the other hand, and I show you in later slides, that you have to monitor in this area because this is the area where a lot of seizures take place. So be careful to use different electrode positions for inclusion criteria for intervention if you want to do this. Because on different areas in the brain, so here again, frontal, temporal, central, occipital, the background patterns in the same patient can look differently. And realize that the longer the distance between electrodes, the higher the amplitude. So if you put your electrodes in a very short distance, then you get a low amplitude. So you have seen this baby before. And now we are in a cold situation. And here you see the prognostic value of AEG in those early hours after birth. And here is in the non-cold situation and here in the cold situation. And you see that if you have a burst suppression, low voltage, flat trace, the prognostic values goes down in those early hours, as you would expect. And if you have a normal AEG in those early hours, then your sensitivity is quite good. And I like to share some examples for this case. This was a baby, this was recorded an asphyxiated baby who was cooled within 6 hours after birth. Here we start off with a burst suppression pattern, recovers a bit, but still very discontinuous. But it recovers within 24 hours. And I like you to focus on this number as well, which is the regional saturation of the brain, still within normal limits. And here you see recovery, 48 hours, no seizures, no sleep-wake cycling, by the way, but normal amplitude of the AEG and saturation within the normal limits. This is at 72 hours, then we start rewarming. And still you have no real sleep-wake cycling, but we see here some imminent, as we called imminent sleep-wake cycling. And after rewarming, we saw sleep-wake cycling, and the regional saturation of the brain didn't go up in this particular baby. And this baby had normal MRI scan and was normal at follow-up. Then we have another case. This is a 40-weeker. And here very bad APGAR scores, as you can see, very high lactate, and he was anemic as well. And he started off with this very bad trace, it's almost flat, few bursts. So we started cooling. 24 hours later, still a burst suppression pattern. Seizures starting. Are you worried in this baby? I think you ought to be a bit worried that the baby doesn't recover within 24 hours and started seizing. So this is 32 hours after birth. Repetitive seizures, and he was on a lot of medication because to cope these seizures. And this was 48 hours. But here the regional saturation of the brain is going up a little, but not very much. And this was 70 hours, still a very depressed trace, with burst suppression here. And so, in this particular baby, we were very worried. And we were very surprised that the MRI scanner day 4 was normal or only some minor abnormalities. So this was one of the first babies we called, so we were not very confident that we did the MRI at a good time point. So we repeated the MRI a few days later and the same result. So we had an almost normal MRI, and this baby at 2 years of age had a Bailey score with a motor of about 110 and a cognition score of about 90. So he's doing quite well, and we are very surprised that we had this depressed EEG, and it turned out that this particular baby who was called had very high levels of midazolam. And so we are not sure about metabolism in those cooled babies and what they'll do, and there are probably a lot of individual things going on as well, because you don't know what liver function is, what kidney function is, and so I think you have to look at that, and you have to take that into account as well. Another example of a baby that was cooled and very depressed trace, and here you see a ECG artifact at this area where it is very suppressed, 12 hours of age, 24 hours of age, with a lot of seizures actually, almost status, and the NIRS going up, and at 36 hours we have a very high NIRS values, and almost flat trace with a lot of seizures. And here's 72 hours, NIRS going down a bit, and 84 hours. And during rewarming, again, some seizures. And this baby was so this is 96 hours, and this baby had severe abnormalities, diffuse brain lesion in a diffuse and weighted image of the MRI, and not only in the basal ganglia, but here the whole frontal temporal and parietal area of the brain, and here in the peduncles as well. So, and in this particular baby, the NIRS did go up severely, quite dramatically, and we looked into this, and you see, even in the cooled situation, looking at NIRS, we had actually the same type of pattern as we had in the non-cooled babies. If babies had a bad outcome, so severely handicapped or died, then the saturation of the brain is going up after 24 hours. And another phenomenon that was just addressed to just recently is that in the cooled situation you will have less seizures. And this was studied by Leuven, that's in your handouts as well. And you see that there's a tremendous reduction of seizure activity in these moderate HIE babies when they're cooled. So what about seizure detection? As Roberta Cilio already pointed out, we are very bad at looking at clinical signs. What are seizures, what are not? So even if we are trained, we miss a lot of seizures. You see here that of the clinical seizures in these babies, this was the study she referred to as well, only more or less 25% were found as clinically and appreciated as seizures by the staff. And there was a lot of overdiagnosis as well. And you see that there wasn't any agreement, the medical staff, what was seizure. So it's important to monitor. And here you have a single seizure on a reasonably normal background, and you have here seizures on a flat background pattern, repetitive seizures on a normal background pattern, and what we call a sawtooth pattern as a sign of a status. And here you see the seizure patterns in a new OBM machine. So this is quite recently. And here you have a seizure detection that gives you these orange bars at a period when the baby is seizing. As already was pointed out, we have a lot of subclinical seizure, we have uncoupling after medication. It's important to monitor those babies. We looked into the problem of AEG versus EEG. Do we see all seizures? What do we miss? And this is only looking at AEG without access to the raw EEG. And we see about 80% detect seizures in about 80% of the children, but obviously we miss the frontal, occipital, and low amplitude seizures and of short duration. And this was addressed by Schelhaas, who looked into full EEG where the seizures took place. And the seizure burden in neonates is very high, and especially in this central temporal area. So that's the location you want to monitor, and that's what we do in the one-channel AEG. So, and these seizures are not staying in one place. They're just about moving around, you could say. And in these babies, they're 94% of the EEG recording, the seizure once or another time was in the central region. So we have to look into this region. You have to monitor this region despite of this ECG artifact. So if we look at two-channel EEG with access to the raw EEG, what do we find then? And this was addressed by Shah. And here you see, if you have a two-channel EEG and AEG, and you have access to the raw EEG, then your sensitivity and specificity is quite good. So here you see another example of an asphyxiated baby. And you see here, at 3 hours after birth, you see this ECG artifact. And then here, 12 hours after birth, and this is care. It could be a seizure, but it was care. And you see here a period of seizures. Phenobarb was given. And then the baby developed a lot of seizures, and she was on medication. And at 60 hours, we had a pattern like this. Is this normal sleep-wake cycling pattern? So what is this? This looks like birth suppression, this looks like birth suppression, and there's something in between, we don't know. It's a bit difficult if we see only one channel, and we have some sharp waves, but it's very difficult to appreciate is it really a seizure or not. And if you don't know, still the EEG, the full EEG is the gold standard. So it's very important in your hospital to have a good relationship with your neurophysiologist and to have access to full EEG as well, because this baby was in status all the time. And you can, so in this whole area, so this is about 2 hours of status. So if you don't know, if you find it difficult to interpret your AEG and you don't have a clinical substrate, please ask your neurophysiologist to do a full EEG and to check on your AEG. What about automatic neonatal seizure detection? Neonatal seizures, in the way they present on EEG, are different as in adults, so you have to have other measures for seizure detection, and we saw this in the brains machine, the two-channel machine by Navakatikian. He pointed that here the orange bars are the seizure detection. And just recently, from the Boyden group from Cork, where they do a lot of research on continuous full EEG measurements, they try to have a new seizure detection method and They made an algorithm, and they had this machine learning thing, and they only did it on full-term babies, and now in our unit and in other units, we in the future we'll try this seizure detection method to see how sensitive it is. But on the other hand, we already know that if you have a seizure duration of 1 minute, your sensitivity to detect a seizure is not very high. I mean, and you have a lot of false positives as well. So you really have to realize if you have a very sensitive method to detect your seizures, you will have a lot of artifacts that are appreciated as seizures as well. You have that also. So within an hour you could have a seizure, and the seizure detection will show this. But it could be either an artifact or a seizure, so you have to be sure. And I'll show you some examples later. Do we need two channels, or is one channel sufficient, especially in babies with unilateral brain lesion? As you can see here, that even if you have a unilateral brain lesion, you can have seizures on both sides equally. And sometimes you have even more seizures on the other side. This was all EEG. So, in general, you're not doing it wrong if you only have one channel and you have a baby with a unilateral lesion. You will pick it up most of the time. This is an example of a baby which are called with apneas. And as you can see, this is a discontinuous background pattern here in the EEG, left and right hand side, and then suddenly drop. It's opposed to a gap, what we see more often. And you see here seizure pattern, that's the typical rhythmic pattern. And then just a few instants later, we see this on the other side. So should we treat neonatal seizures? And should we treat subclinical seizures? There was a question that was asked a lot because first clinicians only wanted to treat clinical seizures, and so we were part of the randomized controlled trials in the Netherlands and in Flanders, and we saw that there was actually a very difficult randomized trial to conduct because it was very difficult to get consent in those first hours after birth in very desperate parents. And here you see group A where we treated the EEG seizures and the clinical seizures as well, so both. And in group B only clinical seizures were treated. And you see that the seizure burden in group B is much higher, but this wasn't significant, probably due to not that much children in this study. But if you see the MRI scan, here you have all babies, here you have group B, so only clinical seizures were treated, and here you have group A, and you see that there were more abnormalities on MRI scan in this group B, where only clinical seizures were treated. See how much time we left. So what about EEG in premature infants? And part of these slides I got from Lena Hellstrom-Vestas, who did a lot of research on the premature EEG in her group in Lund at the time. And you see, you have to realize that EEG evolves with maturation of the brain. And you see that here you have the continuous activity that evolves with maturation, and that was already addressed to in the late 80s. And here you see that with age, with gestational age, your interburst intervals diminishes with maturation. So you really have to bear this in mind. And if you look at EEG, and this was already addressed in the 90s, And you see this pattern from babies here to 30 weeks, almost term, and you see that especially this lower border of the EEG is going up and the bandwidth is getting smaller. And this was also shown in rats, the same thing. And if we look at patterns in premature infants, then we could say that we have, even in 25 weeks, we have patterns like this. But if we have babies with patterns like this is abnormal, even in very immature babies. And this could be either medication, like morphine or phenobarbital, but it could be another clinical condition as well. So these are, even in premature infants, these patterns are abnormal. So these are all data, is still very valid in the sense that how does an EEG in a premature infant look like? And you see that there is some cycling pattern even in those very premature, immature infants. And here you see this periods of quiet sleep. And you see that the bandwidth of the EEG goes up with gestational age till we have this more mature sleep-wake cycling pattern. And this is a way of scoring this. So this scoring system of premature EEGs looks at continuity, cyclicity, lower border of the EEG and the bandwidth. And then you get a score and you can see if this score fits with the gestational age, actually. So do we have markers for short-term outcome in infants with the gestational age below 24 weeks, 29 weeks, sorry. So it's not that obvious that it's in term infants, but it's doable, and you see that there are more markers for poor outcome, so died or severe intraventricular hemorrhages, that the continuity is much lower as in normal babies. And I think these were very nice studies from Sweden, from Sverre Wikström. They looked at EEG, and they looked at full EEG, and they looked at interburst interval in very immature babies, and they looked at glucose levels and CO2 levels in those babies. And what you can see that the interburst interval is the lowest here in babies with normal glucose levels. And when your glucose level goes up, your interburst interval increases as it does with higher glucose levels. And the same thing happens with CO2. You see here you have CO2, that's 9.7 here, kilopascal, so that will be times 7.5 millimeters of mercury. And you see that within the normal limits of CO2, what we consider normal limits, the interburst interval is much shorter than you have high CO2s or even very low CO2s. Here they looked, same group, looked into prognosis in very preterm, and they had these extremely preterm infants and preterm infants. And although these numbers are low, there is a trend, and some are significant, that very depressed traces in terms of very long interburst intervals are associated with poor outcome. So, in conclusion, in premature infants, we have EEG and EEG change with maturation, continuity, sleep-wake cycling, brain injury, physiology changes, and medication, which is very important, are associated with EEG and EEG alteration. Presence of seizures is associated with brain injury, and early EEG is predictive of outcome in preterm infants, but the accuracy is lower than in term infants. And just to show you some examples, this is a normal 25-weeker on nasal CPAP. He was doing fine. He had normal scans. He was normal at follow-up, and still you already see this cyclicity, not really sleep-wake cycling, you can't say that, but there is some cyclicity already at that age. And here you see a 29-weeker who we saw already in the first hours after birth having an intraventricular hemorrhage on both sides. So we put her on EEG, and here you see these seizure patterns, which are very difficult to see if you didn't have the seizure detection, because the pattern of EEG in preterm infants is very discontinuous, so it's very difficult to see the seizure patterns apart from the background pattern. This is another baby which mimics the seizure patterns. And the seizure detection is showing seizure patterns. So you really have to be aware when your seizure detection shows up suddenly what is happening. And this baby was breathing, had an airway obstruction and moving all the time like this. And that's what happens when, for instance, nurses are patting the back of the baby just to reassure them, and they can mimic seizures. Or you have a child on the ventilator that can have a similar pattern with the frequency of the ventilator looking like a seizure pattern. So that can be difficult. I'd like to show you some examples of other conditions. Roberto already pointed out that a lot of that EEGs are important in children who you suspect of metabolic diseases. And just a few weeks ago, a paper came out from Monica Olischer and Christiane Teda to address this problem of metabolic diseases and EEG, how these patterns look like. These patterns are aspecific, but they're different from normal term babies, even if they have seizures. So most of the time you don't see those sleep-wake cycling pattern. You have a lot of seizures, a lot of subclinical seizures. So I think it's important to look at this. And this was a child with a real cycle defect with very high levels of increasing levels of ammonia. Here you see the background pattern, and this was the next day with a lot of seizures. He was treated for these seizures, and then the background pattern went in burst suppression, almost flat, and he continued seizing, and he had a status which wasn't treatable actually in this particular baby. And here we have a term infant with a group B strep infection. She came in the hospital in a very bad condition on day 2. She had the pulmonary hypertension, and she was on the ventilator with a lot of inotropic support. And so she was in a very bad condition, but the EEG looked very reassuring with a normal, almost normal background pattern. And on day 7, she was still on the ventilator, still quite ill. She was in high frequency oscillation. And we have this normal sleep-wake pattern on the EEG, so that was reassuring, still reassuring. Ultrasounds were normal. And here we see a sudden decrease in the EEG, almost a flat trace with some ECG artifact, as you'll see here. And it turned out that this baby had a tube blockage. And we couldn't see this immediately from the high frequency oscillations, and were normal oxygen levels, so apparently nothing changed in the ventilator settings, but we found out that this was tube blockage, and there was very high CO2 levels in this baby, and when we found that the CO2 levels returned to normal, and so did the EEG, as you can see here in this baby. This was a baby from another hospital, day 5. It was a little Chinese fellow who came in with high bilirubia, and this was more than of almost 600 micromoles per liter. And this baby obviously had seizures. I was treated with phenobarb and then referred to our hospital, and we had this depressed pattern on the day he arrived, and the next day he recovered with a nice sleep-wake cycling pattern. And this was his MRI scan with abnormalities, as you would expect with kernicterus in his basal ganglia. So I can continue with a lot of examples, and I think you have to find out for yourself as well, just to try and see what happened, how EEG evolves over time. And I think that the message I want you, your take-home message I really want to address, if you don't understand your EEG and you're not familiar with it, please talk to your neurophysiologist to make it a continuous, a full EEG, just to check what you're looking at, and ask other people who are more experienced to look at your traces and if your evaluation is the right one. Okay, thank you for attention.
It is subclinical or not, but